that, it would be, yes, it would be the mesocolon. And then on top of that would be the omentum. And both of those put together are going to be called the mesentery. Yes, so that was what those terms were. Now, you sound like you had this question before. You didn't have this question.
I just learned it.
Okay, I'm glad you learned it so you can remember what it is. Okay, so the mesentery is what all of those things are. So hopefully you're ready to answer my questions. For our folks who just came in, we are writing them down because now we're paper people. Or you can take a picture with your phone if you're still a phone person. However, the warning was you have to go back and write down the stuff that was in your phone. So as we look at our integumentary system to produce vitamin D, that was, now if we're doing this for the general term, that was the digestive. The digestive is usually going to have its small intestine. So what was that thing in the small intestines that I said it was? It was the ileum. Somebody remember. However, we're just going to talk about the general, not the specific. So that would be the small intestines. Okay, so if we had our thing for the abdomen hangs directly over small intestines, and large intestines, hold on a second, directly covers small intestines and large intestines. I think I want the one that's closer to and not farther from. So we're going to say that one was the mesocolon. And we know the one that hangs over the mesocolon is going to be called the, oh, yeah, with the over. I was getting ready to say it. And then we got our first pathology question for today. This one I didn't preference you guys or prep you guys for. A combination of food that would cause a person to gain oranges, discoloration of your skin. Would be carrots and squash. You said you were close. You said keratin. Keratin is actually what the skin is made of. Those are dead protein cells. So carrots, the actual vegetable carrots, and the actual fruit of squash. Okay. So those are be like pumpkins. And it's getting ready to be pumpkin season. What? Who had a question?
You right.
Oh.
Sorry.
I'll write it down.
You had it written down?
No, I'm gonna write it down.
You sure you're gonna write it down? I've been warned. This is the thing.
I'm sure. I got it. I'm ready.
And that's what the micro teacher said.
What?
That you gotta write it down?
Yeah.
Okay.
I just understand it better when I do that.
All right. I'm assuming. Hold on. Let me do my little head check. You got a picture? You got a picture? You stretching back there? You praising the Lord? Whichever one is both of them. All right. We moving on. Okay. So we're doing our thing here. We're moving to another system, which is going to be for the muscle system. Now with the muscles, we're going to have a very specific focus on very particular names of muscles. So we actually have to know what the muscles do. And we have to know some very specific names for some muscles. So the muscles themselves are going to have some, you see those questions, they're going to have some names for them. They may even have some descriptions for them, which we'll get to when we get to the muscles. So with that being said, we are looking at skeletal muscle. So skeletal muscle will be the focus. They don't have any questions about smooth muscle. If they do, they're new and improved and I haven't saw them before. They don't have any questions about the cardiac muscle. We do have some about where the heart beats and that type of thing, but when we get to the vascular system, we'll talk about that portion when we get to it. So with this course, we're going to focus on our skeletal muscle. So we can underline or highlight that on page 6. Go to page 7 for me. Underline or highlight about 4 things for me. We're going to take a highlight on flexion, extension, abduction, adduction. And then down towards the bottom, we want ball and socket joint and hinge joint. I'll repeat that again. So on page 7, we want flexion, extension, abduction, adduction, ball and socket joint, and hinge joint. All right, so I'm back on page 6 here. We got our skeletal muscle. Now remember, the skeletal muscle is going to be what moves the joints and limbs of the body. So a joint is any place where 2 bones are what we call articulated, which is the word that they're going to use for the Hesi test, and that is what usually is going to form a joint. Now there are several different types of joints, which we'll look at after we go past the muscles. For our movement is what we're going to really focus on for the next segment. So when we say that, with our striated muscle, usually those striations are going to be what are going to be called fibrils, and they contract or they expand. As one muscle contracts, the other one is going to expand, and that's usually what causes the movement for a particular part of the body. So we're looking at this for our movements here. Our flexion extension is going to occur where we decrease the angle of two particular bones for a plane, and that will be called bringing it in, or flexion. When we increase the angle, we're going to call that extension. So if I increase the angle between two bones on a plane, that would be called extension. So our extension is usually going to happen in the same place where flexion would happen, and we'll learn to look at that in just a second. The abduction, adduction, I ask you guys to be conscious of, is going to happen when we take a joint and we move it away from the body. That's going to be abduction. Moving it towards the body is going to be called adduction. So moving it towards the body or away from the body would be abduction and adduction. So that is only going to happen with a very specific type of joint. Other types of joints are going to be very exclusive with very specific parts of the body. Turning on an axis called rotation. Sliding up or sliding down, that happens in about 6 or 7 different places. For example, turning your palm over is going to have these two bones in your forearm slide off of each other. That's going to be supination and pronation, and that's got nothing to do with your wrist, because most of those are going to slide or have a hinge to them. And flexion is going to be for your foot, as the ankle slides off of the bottom portion of your bones for your leg. That'll be called the dorsiflexion, raising the foot up, and pushing the foot down will be plantar flexion. So with our foot is going to be a different type of joint altogether as well. So we looked at our ball and socket joints, which we're going to take a look at. I'm going to pull the picture up here for you guys. That'll be usually what's going to be in your hip and your shoulder. So literally, the end of the bone is going to have a ball on it, and it's going to fit into a socket. When we have that for the shoulder, and it's sitting there between the scapula and the clavicle, we call that glenoid fossa, and it sits in a little pocket for what the top portion of the humerus would be. When you sit that for your hip, it's going to be a little pocket, which we call acetabulum, and it'll have a ball at the end of your femur, and that'll be what creates your hip. So that is where the abduction and adduction is going to occur, and usually that's going to be where the 360-degree range of motion will also occur. So if we had this just for the flexion and extension, that will be in a place that's going to be a hinge joint, which would be placed like your elbow or your knee. So in your elbow or your knee, we'll have that where it can raise, extend the angle or increase the angle. That will be what we call a hinge joint. Now there are other types of joints, like I said, we've got the condyle joint or the sliding joint. Some of these joints aren't going to move, and they're going to be called a suture joint, which is where the bones actually fuse together. So when the bones of the skull fuse together and they make plates, we call that a suture. It's different than the bones in your hand, because they actually move, and when they move, they don't move very far, so they just slide off of each other, and that'll be called like a condyle joint in your ankle and a condyle joint in your wrist. So those would be what our sliding joints are going to look like. Hopefully you're paying attention, and the debate continues on whether we're paper people or bone people, so I'm going to have to keep on moving, whichever type of people you guys are today. What would be an example of the hinge joint? What name did I give specifically? One of them was elbow. What was the other one? Knee. That was the knee. All right, which one of the, knee. Which one of these is going to be an example of the ball and socket joint? I said one of them was the shoulder. What was the other one? That was the hip. Okay, paper people, go to it.
Picture time.
I didn't say that.
I said it for the.
Oh, okay. See, why you gonna tell her that I'm gonna move to the next slide? This is why I come on Saturday, just for amusement. Okay. You look like you took this class before. Did you take this class before? When did you take this class?
Back in June.
Did you take the Hesi class?
Not yet.
Okay. You finna take it.
Yep.
Or you about to. That's a medical term. Listen here, Lefty. Don't be telling them about my medical terms. I did not make that up. That is what they say when you go to bed. They say, no, we finna do the thing. And we about to. Yes, I have to tell them the other portions of the medical terms. They don't understand what they don't understand. Moving on from there, we got our actual bones, and we're going to actually have our actual muscles on this board. Go to page 8. Okay, so I will tell you what they are. I'm going to write down what they are, because we got a few of them that I have to actually write down. On that page 8, we're looking at this for our face. I'll go through the muscles of your face, underline or highlight where it says zygomaticus and masseter. Then go down for where it says the lower leg, underline and highlight where it says the gluteus maximus. I'll write down 2 other terms that we're going to need in just a second once we get to our bone muscles for the lower leg. So we're going to have our muscles for the face. Now we have a muscle which is going to raise the eyebrow, lower the eyebrow. That's going to be our usual occipital oculi and our occipital frontalis, controlling for the forehead. And I have our muscle which is going to open and close the jaw. That'll be for the masseter. And we're going to have our muscle which is going to help us turn the neck. Here's another one that goes with the sternocleidoid mastoid, but I can't remember the name of it, so we'll just let it be with that. Then what helps us chew our food we call the masseter. Remember that was for the deglutition. Now when we did our flexion and extension, we looked at what the action was, but we didn't look at what the muscles are called. On the top of your arm, you're going to have the bicep, and on the bottom of the arm, you're going to have the tricep. And usually if one of them extends, the other one's going to flex, so what makes your arm bend in and out is going to be the bicep and the tricep. Now the same thing's going to happen for your chest. On the shoulder, we're going to have the deltoid, and on the back of your neck, you'll have the trapezius, and then on the shoulder, you'll have the pectoralis major. Going over towards our lower leg, you're going to have a couple muscles which you're going to be asked about exclusively for the Hesi test. So we'll have our largest muscle, we'll have our longest muscle. All right, which one we had to guess, our largest muscle is going to be the muscle that you're sitting on, and it helps you move your leg back and forth, called the gluteus maximus. And then our longest muscle, which is going to run, we can't even see the top of it, run down from the top end of the femur down towards the bottom of the knee. That is going to be called the sartorius. Okay, and then that'll be on the inside. So the largest is different than the longest for the actual muscle, which is going to be in your lower leg. And then for your muscle, which will be over here on the outside portion of your leg, that'll be called the vastus lateralis. So I'm going to ask you guys those questions in just a second. Now, one of the things that new people told me about, which was for the Hesi test, and people who have taken the Hesi test before, we'll see if she remembers. Did they ask you about quadriceps? I don't remember. Oh, what was that? That was not. Oh, yeah, they did change it, so that's why I'm asking. So in case when you get, just act like it's all great. So they may ask you about quadriceps. So that's why I told you guys not to underline it yet, because the names for the quadriceps are very, very weird. Quadriceps are things that have a direction to them. So we talk about the directions in book 1, but you should know the directions. If they say something like the anterior or the medial, those are directions. Usually those are going to be hamstrings or quadriceps. So a ligament has a name to it. Usually, if a person were to tear their anterior cruciate ligament, that would be what keeps the knee moving backwards and forward. Same thing for the MCL, the median cruciate ligament is going to keep the knee from going from left to right. So those are going to be different than what we have if we had talked about ligaments and quadriceps. Hamstrings actually have a name to them, and these are going to be very specific, because they're called tendons. So what does a tendon do? A tendon keeps a muscle to a bone. So a tendon keeps a muscle to a bone. So biceps femoris, semimembranous, semitendinosus are all going to be hanging off of the knee, either on the top or on the bottom, and they are going to be hamstrings. So they may have the question about hamstrings. I don't remember if I put the question about hamstrings, it's a newer question, but you may want to remember the hamstrings, put a little star next to it. Then the muscles on the bottom of the leg, which raise and lower the knee and the heel, gastrocnemius, and the soleus, both are going to be on the bottom portion of the leg. They are not hamstrings nor quadriceps. So the things in your knee, MCL, ACL, anterior cruciate ligament, and medial cruciate ligament, all those are not going to be considered quadriceps or hamstrings. They're going to be called ligaments. So they're very specific names. So they will ask you that, and you'll probably see that down there and say, oh, he said that was not a thing. So remember if you see that question. So let's go to our question, which I just prepped you guys on asking and answering, because I wrote half of the answers up here. So let's see what we got. So the longest muscle in the body was which one? Before I erase it. All right, somebody wrote some stuff down. And then the name of the muscle that runs along the side of the femur and the quadriceps, that is called? Yes, vastus lateralis. Now when you say stuff like that, it makes me think you took this before. Yes. Oh, you just knew it?
Yeah.
All right, Maximus. And that means that your teacher actually taught you some stuff. All right, Maximus. All right, and then the longest muscle is going to be the sartorius. All right, so our pool of knowledge is constantly evolving. That's why I try to change these presentations. If you saw this before, of course, you noticed there's some new stuff and new pictures for you to take, but we said we're going to write this down because we don't look back at the phone. Okay, all right, if you say so, we're going to let you believe that. You're going to look at the notebook? Okay, at least you look at one. Oh, I'm sure. Now hold on a second. You want to take a selfie with the thing? Take a selfie. All right, you going to put it on Facebook Live? Okay. Now I'm just acting up. All right, let me move our thing over here. I see here, I see some old schoolers, still old school with me. He said, take your time. Okay. While you're doing that, I'm going to my next thing here. You guys go to page 9. On page 9, we start talking about some bones. Write down some stuff here on some bones. It's going to be on the slide in just a second. So we're going to underline or highlight where it says cancellous bone, red bone marrow, and we're going to take the epiphysis. So one more time, cancellous bone, red bone marrow, and we're doing the epiphysis on page 9. I said cancellous bone, red bone marrow, and the epiphysis. All right, most folks already got it highlighted, so I'm moving on to my bone groups. Now you do have to know some names of some specific bones with some directions. So our bones are going to be first, where do bones come from? Bones come from bone cells, but they have some very specific names. Give me a minute here, see if I put that on here. There you go. All right, so we got our bone cells here. Now let me go back a second. I'll do this in the order that I put it in before I put that up there. Okay, so we got our cancellous bone, which is going to be essentially a different name, and it's got two different names. It's got trabecular bone, and it's got red bone marrow. So this is really the flat, the spongy, porous portion of the bone that is usually going to help where synthesize both bone cells and red blood cells. So this is where those stem cells are going to be found, where other cells are going to come from. So bone cells come from other bone cells, and there's a very specific name for it. But thank goodness you don't have to know the name of that. They don't ask you for a Hesi test. Compact bone is usually going to be what stores calcium and fat. Usually it is not in the spongy place, but in the brittle place where we have what's called the matrix of bone. So that would be where most of the calcium is going to be, and this is what makes the bone as sturdy as it actually is for that compact bone. So bone cells, like I said, come from other bone cells. If you have this, please write it down. Okay, write it down in your little notes next to cancellous bone.
Picture.
So, or you can take a picture, but make sure you look back at the picture. So osteocytes are going to come from osteoblasts. So the osteoblast is what we call the immature bone cell, which is fresh off of the vine from a stem cell. So the osteoblast is going to grow and then eventually will mature into being called an osteocyte. So the bone cell, which is doing its job, and we see it doing its job, the what we call a mesenchymal stem cell. Now remember, you don't have to know that. What we do need to know, remember, is that osteoblast, which is the immature bone cell, and I got the little picture there. It turns into the osteocyte when it actually starts doing its job. Now what we call the osteoclast is going to be an old bone cell, which is going to reabsorb our worn out osteocytes and then regenerate them into new osteoblasts. So if I asked you where bone cells come from, that osteoblast is the obvious line. The top line is where we go to get our bone cell from the osteoblast to the osteocyte. Some people just learn better with pictures, so I had to actually find a picture of that. So that's where our bone cells come from. So when we look at our red bone marrow, now the red bone marrow is also going to make up that hematopoietic stem cell, which is going to be where red blood cells come from. So it doesn't matter how old a person is, because they may ask you, where does it come from in an infant or where does it come from in an adult? It comes from the red bone marrow. Now in that red bone marrow, it'll be in the flat plates. Usually those are going to be like in the discs of your vertebrae, in the flat plates in your chest, or in the like your actual rib bones, or in the flat plates in your hips, or in the nice spongy portion at the top of the femur and the top of the humerus. So those are going to be where deposits of red bone marrow are going to be. And the red bone marrow is going to have those stem cells to make both of those types of cells for the bone cell and for the blood cell. Thank goodness we don't have to learn about the processes of the bone, but we do have to know about the parts of the bone. So if we looked at that bone there, where you see the head of the bone, that is usually going to be called the epiphysis. Now the epiphysis is going to go and it's going to flush out until it gets to be more slender, and usually that's going to be called the diaphysis. But the head of the bone is going to be the epiphysis, and the shaft portion is going to be called the diaphysis. And then it flushes out. As it flushes out and becomes wider, they call that portion the metaphysis. So it's three different portions, but if I were to ask you specifically about the head of the bone, it is called the epiphysis. So let's take a look. Like I said, you don't need to remember where that those processes are, but a process is going to be a thing that is going to hang off of the bone. Usually that's going to be for where the, which one did I say? Which one is the muscle to the bone? Is that the tendon or the ligament? You guys remember? Muscle to a bone, tendon or a ligament? Tendon. And a bone to a bone, ligament. Okay, that'll be where those things are going to hang off from. Some of you guys just woke up like, you said that? I didn't know you said that.
You said bone to bone.
I said bone to bone was ligament.
Okay.
And I said muscle to bone was ligament. I'm lying to you. I said muscle to bone was tendon.
Why would you just tell me that? I was being
See, I wanted her to correct me, because she said this was on there, but she didn't write it down last time. She wrote it down and highlighted it. So you don't look at my little book this time. It flatters me, because I wrote this book with you in mind. All right, so we got our questions coming up here.
What's the actual answer?
A bone to bone is a ligament.
Okay.
Muscle to bone is a tendon. All right, where are blood cells created? I just said that, but I forgot what I said. Was that in the yellow bone marrow? Oh, that was in the red bone. Okay, and now you could say hematopoietic stem cells, but that's not a thing. So don't have to worry about it. Which ones are responsible for the formation of the bone? I heard somebody say osteocytes, and that's what a bone cell is called. So it is osteoblast, B-A-S-T, and I heard somebody say that, which is correct. And then what's the process of ossification? I will tell you very simply, it is the process where bones fuse together. Okay, so if we had our bones and they fuse together, then that is the process for ossification. All right, give me a minute here. Let me do this way. Who is slow rolling me back here? I said, don't write these down.
I know I'm writing the last part to the last
Write
question.
those down, but don't write this down. Okay.
Okay.
Now, you slow rolling me?
Okay.
Can I
Yes,
slow
ma'am.
roll you one
Hold on a
time?
second.
If you can go back to that slide with the, I'll
Which
see
one?
on
I can't go backwards because that takes too long. Which one would you want to know? I might be able to
I want
tell
to
you.
take a picture of that slide.
Oh, but I'm slow rolling, so it's gonna take. Love Saturday morning. Give me a minute, I'll flash it back up there, and we gotta move on. We got a lot of other stuff to talk about.
Okay.
Okay, which one did you want? The one with the bone cells on it? That one there?
Yeah, thank you.
Okay, moving on. Page 9 and 10. All right, on page, there's a lot of these to highlight, by the way. Okay, so I'll go slow. Please pay attention because I don't want to repeat this. All right, on page 9, on page 10, we're going to underline where it says sternum. Underline where it says, that's a sternum. That's bones in the chest. We're going to underline where it says humerus. Underline where it says ulna. And we're going to underline where it says, let me get some of my bones here before I forget where I am. On page, so we got our, one more time, sternum, humerus, ulna, radius. On page 10. On page 11. Pelvic girdle. We're going to have our pelvic cavity, femur, and I think we got tibia. One more time. Pelvic girdle, pelvic cavity, femur, and tibia. All right, so that's our 10 and 11. Moving on. So we started our bones out in the chest. We're going to have our thing for the rib cage. Now remember there, for the chest, it's called the thoracic cavity. We're going to have at least 12 ribs, and all of those ribs are going to be connected towards the middle of the chest, which is going to be called the sternum. They're going to go around from the back to the front. They're going to form with this bone called the sternum. Now on the upper portion, that's going to be called the superior portion. It's going to be called the manubrium. That actually connects to our, what we call clavicle, which is going to be our collarbone. The collarbone goes back towards the posterior side, which means the back, and that's going to help us make up that glenoid fossa, which creates the shoulder cavity. Now on the ribs that are coming down from the sternum, we're going to have 7 of those connected directly to the sternum, and those are going to be called true ribs. Now we're going to have about 8 through 10, they're going to be connected with this cartilage, but they create this nice air pocket or cavity, which is where the lungs sit, and those are going to be called false ribs. Now you'll have 2 more ribs after that, and they're going to be 11 and 12, and they're going to be called floating ribs. They are connected to either the cartilage or to the sternum. So remember that for our sternum, we have the top portion, the manubrium, and the bottom portion called the xiphoid process, but we also have a bunch of ribs that aren't connected towards the sternum. Moving on from there, we're going to take a look at our arm. Now the arm is sitting inside the glenoid fossa, which creates that ball and socket joint. On the back portion, we got the scapula. And on the anterior portion, we got the clavicle. Now as it sits in there, it's going to have that 360-degree range of motion. Now remember this, on the distal side, which is farther away, it's going to articulate, which means form a joint with 2 other bones. Those 2 bones in your forearm. On the thumb side, it's going to be called the radial, and on the pinky side, we're going to call that the ulna. So it'll articulate with the 2 bones that are in your forearm on the distal side. I'm pointing this out because I know somebody's going to say, I don't remember what he said. The thing that is closely attached to the trunk of the body is called proximal. A thing that is farther away from the body is called distal. So if I say what's on the distal side, it doesn't matter what I'm talking about. I'm saying it's on the far side, it's away from the body. On the far side of the ulna and the radius, we're going to have our hand, which is going to have 2 rows of 4 bones, and that's going to be called our carpals. Now most people would think that that would be the wrist, which they're actually correct. We just want to say that the wrist is the articulation point between the ulna and the radius, and the carpals are what they articulate with. On the fingers, which are called the phalanges, you actually have those terms written out. I don't know if you could see them on your paper, but you can see them on my slide. Proximal, medial, distal, meaning closer, middle, and farther. So as you have 3 bones in each of your 4 fingers, you only have 2 bones in your thumb. Same thing is going to happen with your big toe. All right, hopefully you heard all those things. She's writing this down because she's not a phone person anymore.
You said closer, middle, farther?
Yes, proximal, medial, distal. Closer, middle, farther. That's what they are. Did you write that down? You want to say it again? Closer, middle, farther. I can't move too much slower. So we got our names located at the distal end of the humerus. Is that closer or is that farther?
Farther.
All right, somebody remembered that. 4 stages of repair of broken bone are up there, but this is a different type of Hesi test question. This is the type of Hesi test question where they tell you the stuff and then they mess with you. They're going to put these out of order. So I put them out of order, just like the Hesi test question would be. Later, we're going to put them in order. So those 4 things that are out of order, don't write them down yet until I put them in the correct order. Those are what the 4 stages of repairing a broken bone would be. What's the bone on the superior side of the sternum? And which of the bones articulate? Remember that is form a joint with the carpals. Okay, let's see what you guys said. All right, so this located on the distal end of the humerus, that was the ulna and radius. All right, on the superior side, was that the xiphoid or magnum? I forgot. A person. Somebody said it already. You know what? They took you off the hook on that. I'm gonna get you next time. All right, and then on the distal end, the far side, this is where my hand is, and it's the distal end with the carpals. That would be the same thing as the first question, ulna and radius. I just said the pinky and the thumb. That's what I meant. Okay, so we got 1, 2, 3, 4. So the way this question is going to come up is you'll have all 4 of these things: callus formation, bone remodeling, ossification, and hematoma. But your job is be to put them in the correct order. So we'll say 1, 2, 3, 4. The first thing is going to be hematoma. Hematoma. All right, if you were to ask Professor Google 4 stages of bone repair, he would say hematoma. All right, what do you guys think would be the next stage? Hematoma is done. Which is the second one? It would not be ossification.
Callus formation.
It would be callus formation. All right, we got 2 more. Callus formation. All right, give me a good educated guess about what the third one would be. Now we're down to, all right, now we're down to bone remodeling and ossification. Which one is going to go third? Ossification would be third. That is correct. All right, and then the last couple. Yeah, last one would be bone remodeling. I thought I forgot something a minute ago, but I remembered that I didn't forget. Okay, so write those down. Those would be the 4 stages of repairing a broken bone in the correct order. So what you'll see is the question pop up, and then you'll have all of those things come up with the question. And then they'll all be shuffled around in different order. They'll say callus formation, ossification, bone remodeling, hematoma. You got to put them in the correct order: hematoma, callus formation, ossification, and then bone remodeling, so that they'll be in the correct order in order to get that question correct. They do that again with another question. For example, what are the 3 bones found in the middle ear? That would be the malleus, incus, and stapes. And they'll have them all shuffled around in a different order so that you'll have to put them in the correct order. I'll leave that up there for the parts of the repairing a broken bone. Our old schoolers got to hurry up because I'm running short on time now. I know, right? You gonna have to ask?
Yeah.
See, your neighbors told you. All right, we're up to page 11, and I'm talking about the legs. So you guys already got that pelvic girdle, pelvic cavity, and the femur. So that's what the pelvic cavity looks like. So the pelvic cavity is actually going to be, the pelvic girdle is actually going to be those 2 bones, the ilium, which is on top, ischium, which is on the bottom. And the ischium actually hangs down with an open hook to it so it can attach those ligaments, which are going to move for the big bones and the muscles in the leg, and tendons, which are going to move for the body. So we'll have the ilium on the bottom, ischium on the top. That's what actually creates those two, if we want to call them shark fins, or the dorsal side of the fin, which are going to be attached towards the acetabulum. The acetabulum is a little socket where the head of the femur is going to stick in, and that creates a 360-degree ball and socket joint for the upper leg. So the femur, which is the bone that sits in there, we're going to skip over that portion about the sensus pubis and the sacrum because I'm running a little short on time. But the femur, which is the bone that sits in there, is the longest bone in the body. Now I did add that as a question because some people told me they saw that as a question. So we added that as a question for the longest bone in the body, which would be for the femur, and that is the longest bone in the leg. So as it goes down, it articulates with the foreleg, which is going to be for the fibula and the tibia. Now the tibia is going to be your shin, or an anterior portion of the leg, and it's going to make up for that kneecap. Usually it'll be a synovial fluid, which moves in between that kneecap and your knee socket, and that's going to be called synovial fluid, but it'll also be a sac of cushion or fluid inside of that, which we'll call a bursa sac. So that bursa sac, if you were to jump up and down or while you're walking, it actually slides across the top and bottom portion of the femur and on the top and bottom portion of the tibia so that it can help the joints move without rubbing up against each other. Now the heel of your foot, if we move that down, is going to be the calcaneus and the talus. So we're looking at our calcaneus, that's usually what you put your pressure on. When you're walking, the calcaneus is going to help form the top portion or bottom portion of your ankle because it's going to articulate with the tibia, which is going to sit down in this little pocket there that we see, and that'll be where our talus is going to articulate with the tibia. So as those two slide across each other, like I said, that's a sliding joint. That's where we get our action for the sliding joint with the dorsiflexion and plantarflexion, which is going to be what moves your toe, your foot. Now your toes are going to be made up of the same structure, 2 rows of 4 bones, which will be called your tarsals and not your carpals, in your foot, and then you're going to have 3 bones for each toe. So it'll be the it'll be the proximal, medial, and distal, same way we did it with the fingers, and it'll just be 2 bones for your big toe, which would be just the proximal and distal for your big toe. Kind of like your thumb will be your big toe in your foot. So now we're looking at our bones in the head. We're going to have a whole lot of stuff for our bones in the head. So go over to page 12. Page 13 is all just pictures. And we'll take a look at our bones on page 12. So we got our bones on page 12. Most of these are going to articulate with a lobe of the brain in that first portion, but they're all going to fuse together. And that fusing process, again, is going to be called ossification. So now we look at our bones in the face. We want to remember nasal bone, zygomatic bone, and vomer. One more time, underline or highlight. Nasal bone, zygomatic bone, and vomer. Now the words tendon and ligament are on page 12. So Ariana, you can highlight. And I want you to put it in a different color though. You got that in the pink? Okay, she got that in the pink. Good. All right, and then if we get to it, I don't remember if I put it on there. Put down synovial fluid, which is the fluid that lubricates the bones so that they don't rub off with each other. And then we got the actual names of the ligaments. Remember, these are not called quadriceps. On the bottom of page 12, the ACL and the MCL, we'll put them in there just so you remember what they are. So I'm going to look at my pictures on page 13, and I'm going to carry on. So we got our frontal bone. Now, in the bones inside of the skull, if we took this from the transverse view, which means we're looking down into the skull, we're going to have our bones, which are going to all form or bond with that ethmoid bone. So that ethmoid bone, we see that towards the middle. Let's see, we got our pointer right there. It's going to be right towards the middle, and it's going to bond with the frontal lobe or the frontal bone, which makes the front of your skull. It's going to come up to the sides here. It'll be with the temporal, which will be towards the base of the skull. And it'll be all the way up here towards the top, which will be the parietal, which is going to make up towards the crown of your skull. And it goes back even as far back as to the occipital bone, which will be back towards the where your neck is going to go into the magnum fomentum and form with the base of your skull. So now we look at the face. In our face, I told you guys there are a couple of these that we need to remember. The face is over there towards your left. So on the bones for the face, we're going to remember that there are zygomatic bones where our cheek process is going to hang off for the tendons that help our smile formate. So our cheeks are going to have two bones out here. Sometimes you can actually feel them on some people with skinnier bone structures. Then for our bone that's going to be for your nose is actually two different ones. It's going to be one that comes down and creates the shape of your nose. That's going to be the nasal bone. And then for the one that is going to separate the left and right nostril, it's called what we call the septum. That'll be called the vomer. So you got a bone right there in the middle, and that makes for the left and right nostril for the bone. Now you do have some air sockets in there. I didn't put those up there because they don't ask about the sinuses, but you do see the air sockets for the lacrimal bones, which will be for our tear ducts, which are going to create some air pressure as well. So you have this for your tear ducts, which will be the lacrimal ducts. And on the top and bottom of your jaw, you'll have the maxillary bone and the mandibular bone, which will be for your bottom jawbone. That mandibular bone is going to stick up into this, what we call temporal mandibular joint, and that's what makes it for you to talk. So the temporal mandibular joint will be what moves up and down as you articulate or move your jaw. So now you see the lateral view, or the side view, it's actually called the sagittal view, of the left skull, and then you can see the bottom, middle, and top frill, but you can't see that ethmoid bone, which fuses all of them together. So that ethmoid bone, which is going to be on the inside, is going to be for the frontal, parietal, temporal, and occipital, but you can't see all those. Can't see that because all of the plates on the bones are sticking together. So actually, they may ask you the question, you may want to write this down. The adult has about, what do we say, 206 bones, but the child is about 3 times what that is. They don't usually ask you that, but if they ask you that, the number of bones, because now you can see why there is such a small number of them, because they start to fuse together, it is 206 for the actual person. So that is some of the statistical types of stuff that they ask. Like when we said, what's our longest bone, and what's our longest muscle, and our longest muscle. Okay, so hopefully you're paying attention to those, and we got those types of questions coming up right now. Come on, old school, you gotta write this down. All right, I can't move much slower. All right, which of the facial feature would be affected if the zygomatic arch were broken? Longest bone in the body, that was the femur. All right, and facial bone would be injured if a person suffered from a deviated septum. Which bone was that? All right, that was the vomer. And then the area of the body which is intramembranous ossification. I said the answer. I don't know if you guys are paying attention, but I'll say it again in just a minute here. This was the cheek. Boom. All right, and that would be the plates of the skull. So as those bones fuse together inside of the skull, they become one bone, and that process is called intramembranous ossification. So that we know that, we've used it 3 times now, because first we said ossification, then we said that was in the repair of the broken bone. Now when bones actually get stabilized after the person grows up and matures, we call that intramembranous ossification. So we'll leave that up there for our... Now you need to take the picture if you're not going to do both. Never mind. I think you should, hold on a second, I'm posing now. You didn't get the picture where I'm posing. Never mind, I'll pose for the next one.
Okay.
All right. Our paper people and phone people are just competing for my time today. We're going to move this along in just a second. You're all done? Or are you going to go back? You promise you're going to go? Because allegedly I have failed you. If you don't go back and write this.
I'm going to go back.
Because sister girl here took the test. She said this is on your 7th time or your 8th time. you know, that's what you get when you sit next to Mr. Board.
Hold on, I need to get that
You sit next to Mr. Board. You just get what you get. So you just get close. You just get what you get. You said this is your 2nd time.
This will be my second time.
Okay, well, We gotta keep trying. We got a goal in mind. All right, so we're gonna move on from there. You guys who are up and ready to go, we're gonna talk about the respiratory. It's a very quick talk about the respiratory. I'm gonna do page 14 and 15. So we got our two things here. We got internal respiration. That's it for page 14. Go over to page 15. I'm gonna say you need to know about the thing, but they don't have that on the thing. I'm gonna have to update that, put it on the thing. This is my old way to put some new stuff on there. All right, so we got. I said on page 14. The only thing I wanted you to remember was internal respiration. I'm debating on how many of these we need. 15. I'm gonna say we need. Let's do all three. Trachea, bronchi, bronchial. One more time. Trachea, bronchi, bronchial. We won't do the spaces. I was debating on the spaces, but we won't do the spaces. Okay, so let's take a look at our respiration. All right, so respiration, we got internal respiration, external respiration. Internal is where we move the gases around inside the body. This is done with the circulatory system. We're taking the gases from the lungs, move them with the heart towards the blood vessels, and that's going to be done with the arteries and veins. So we did this with what we call internal respiration. It's actually a different word when we talk about it with circulatory. External respiration involves no fluids. It's just gases. So we're going to take in the air, and this will be the exchange of oxygen being taken in and carbon dioxide being pushed out. And that is where we get our term inspiration and expiration. So we'll follow this pathway of air as it goes on. The air is going to go into the nose. Now you'll have some hairs in your nose, which will be called cilia. They're supposed to filter and warm the air. You have some filters back there, which will be called the adenoid. They're going to filter out for things that you don't want, like dust, mold, pollen. Maybe even cause you to sneeze or cough if it gets to be too agitating. Then it'll go down towards your mouth. You have the tonsils in the back of your mouth. They're not very good for air type of things. They're mainly better for food type of things. So the mouth is probably not the best place to be taking in air. So a lot of breathing people say breathe through into your nose. So as we go past that, we're going to go down towards our trachea. Now in the trachea, which is our airway, we need to have a little doorway open called the epiglottis. Now, if the epiglottis is open, it's going to allow the air to go down the windpipe. Now, in the windpipe, you're going to have a set of vocal folds that vibrate off of the trachea. Now, that's going to be called the larynx, and that is your voice box. So if you have a very light voice, then you have very thin coils inside of that larynx. If you have a very heavy voice, then you'll have very thick folds inside of that larynx. And as they move up and down, in a male, you can actually see the Adam's apple move top and bottom as the voice is going to articulate. So now we move from there, we're going to go down towards your chest into our lower respiratory. And in our lower respiratory, we're going to have those terms we just looked at. We're going to have our windpipe, which is going to be 4 inches, a 16 C-shaped disc, which is going to go around and give it its air pressure and structure. As it goes from the left and right lung, you have 2 lobes on your left and 3 on your right. And there are 5 lobes of your lungs. There's actually a space so that the heart can sit on the left side. So it'll go out from the trachea to the bronchi. As it goes out towards the bronchi, those are still going to be covered with cartilage. As it goes to the bronchioles, those are going to be covered with smooth muscle. So the smooth muscle is going to be usually what affects people who have asthma, COPD, emphysema, because they may contract or they may get inflamed, and they may cause pressure in the air as it's passing on from the chest and give the person difficulty breathing. But the objective of it is to get to those alveoli. Now the alveoli are going to be small sacs that are on the end of each of the person's breathing or airway, so that they can do the exchange portion. We're looking at that now on the bottom portion of that picture. They can do the exchange portion with the taking in the oxygen and pushing out the carbon dioxide. So we want to take in probably about 10 to 8% of the air that you breathe in is oxygen, and most of the air that you push out is going to be carbon dioxide. So it may be other wastes that we don't necessarily need. However, what causes this reaction to happen is the buildup of carbon dioxide. So as the alveoli start to say, hey, we're getting a little short here on the oxygen deal, and if we got too much carbon dioxide, that's usually what stimulates a person to breathe inside of the lungs. So the alveoli actually do all of the control, so a person who can't breathe very well may be breathing more rapidly than a person who's taking deep breaths. So as we go to our spaces, we're going to see our spaces. We'll have those in between the lungs. I'll flip back to that. There's a space in between the lungs called the mediastinum. That's where the heart sits. The lungs are actually lined with the inside and outside covering called pleura, visceral pleura, and parietal pleura, both to keep them from rubbing up against other lungs and to keep them from rubbing up against the chest or the bones of the chest, and they lubricate themselves so that they can move more freely. And a big muscle down there on the bottom is called the diaphragm. It actually is going to contract when you take in air, and then it'll relax when you push out air so that the lungs will go back to a resting state. So it's always working to pull in air and to push out air, kind of like a little vacuum. With that said, we've got a couple questions here, and we're going to move on from the respiratory. Old schoolers get the old schoolers. What is the primary stimulus that causes breathing? A buildup of who?
Carbon dioxide.
All right, I haven't said this yet today, but I'll say it again. There are no abbreviations on the Hesi test. So if they use big words, you got to know the big words. So they're not going to say CO2. They're going to write out the whole word carbon dioxide. All right, what is the name of the measured amount of air pushed out by a normal breath? Some of you may know that, some of you don't. It is called the tidal volume. Who took this before and knows that thing? And then which system circulates the oxygen throughout the body? That was respiratory, right?
Circulatory.
All right. What? Circulatory? That's, inside of the body. Oh, yes, I said that, and I said be prepared for that. That was circulatory. All right, circulatory system. Okay, well, let's see here. I'm getting out of the way. Oh, now you want to take a picture? No, I was going to leave it up there. I'm going to let the old school live all day. Well, I got to tell what. I know, Ray. I'm the one that's doing all the talking, just to back it how I feel. That's why I focus so hard. And you're going to ask me 4 more questions, actually.
I'm not going to ask no more questions. I'm done with questions.
I'm teasing you now. Okay. See, I bother her too. It's not just you. I bother her. All right. Everybody looks like they, somebody in the back still right.
I'm still right.
All right, I'll leave that up there for a second. We're getting ready to change tune over to arteries and veins. Go over to page 16. Everybody else who took the picture or is done right. Underline underneath arteries, we want 3 of these. We want our carotid, we want our radial, and we want our popliteal. One more time, just arteries, carotid, radial, and popliteal. All right, then we're going over to page 17. I'll say it again extra slow. Waiting on our old schoolers to write stuff down. They say I'm moving too fast.
It's in front of you.
All right. So we got one more time, arteries, carotid, radial, popliteal. I said skip veins. We're going over to page 17. We got systemic circulation, and we got ventricles. One more time, 17. We got systemic circulation, and we got ventricles. All right, we got to move on, old school, so we move on to the circulatory. On the top portion up here, we got the arteries. Now remember, the arteries are going to be covered with muscle. They're going to move with that same peristalsis that moves your food around, except they're going to be coordinated on a different speed. Usually that's going to be the speed of the heart. So as the heart's moving, the arteries are moving, and they're going to keep up the pressure to move blood away from the heart. So that is going to cause the pressure to move as the heart contracts. So there's 2 different speeds, which we don't have to know, thank goodness. The diastole and the systole, and the systole is going to be that contraction phase. That's usually what helps to measure your blood pressure. How hard the heart has to move to get the blood out into the rest of the body. So now once the blood goes out It's going to go towards the capillaries, which we see down there. We'll take a look at the capillaries in just a minute. And the capillaries are actually going to do that exchange thing that we were talking about with the lungs, taking in the oxygen, pushing out the carbon dioxide, and then moving that towards the back towards the veins, so that the veins can take the blood that's low in oxygen and pull it back towards the heart. Now the veins don't have as much muscle. In fact, they work off a system of gravity. So the gravity is always pushing the blood down. So we have those little trap doors called valves, and that keeps the blood from going the wrong way. Now if you're a bad phlebotomist, some of you are, and you stick that valve, then you can break the valve, and then you'll have a big old plot of blood sitting on top of the skin, and that's called a hematoma. So that was one of our words that we had when we were trying to fix the broken bone. So we don't want that to happen inside the vein. So looking at our arteries here, our arteries are going to go towards certain bones. As they go towards those certain bones, they're going to lie on top of those certain bones for their directions. And usually, you're going to have some that are going up towards your head. That'll be the carotid. You're going to have, and that'll be on the left and right side of your neck. You're going to have some going out towards your arm. That'll be the axillary. As it goes down to your arm, it'll be going towards the brachial, and then out towards the thumb side and pinky side. So on the thumb side, we call that the radial. There's a flat bone at the end of your radial, which most people press against. Never press against it with your thumb. Just do it with your two fingers. That'll usually be what we call or palpate as pulse. So as we palpate the pulse, then we can feel how fast or slow the heart is beating. So when we go down towards the, what we call descending aorta, it's going to split, and the descending aorta actually goes toward, you're not asking no more. Okay. So go ahead. I'm focused. I'm going to keep my train of thought on the tracks. What's your question?
Doesn't the thumb have a pulse as well? That's why you don't press down on it with your thumb?
Yes. Yes, it does. Very good point. Not on the Hesi test, but very good point. So if they ask you that, they ain't going to ask you. It's going to say, if they ask you, does the thumb have a pulse? They're not going to ask you. That's why I don't bet you. But yes, that's one reason I say use these two fingers next to them. Going down towards the descending aorta, it goes out towards the left and right kidney. For next week, next time you guys see me on the 12th of September, I'll be talking about the kidneys exclusively. It's going to go down past the kidneys towards your left and right leg. It's guided by bones in your hip, and it goes out to the left and right femur. So as it goes out towards the left and right femur, then it's going to go towards the kneecap. So the kneecap, again, is the popliteal, and there's a pulse that sits behind the knee, and then the pulse that sits behind the knee is going to be the popliteal. There's one on the top of your foot, which we're going to call the dorsalis pedis, and one on the bottom of your foot, back of your foot, which we'll call the posterior tibial. But they won't ask you about those two. It's just nice to know about. Now the veins are going to follow the same as the arteries. Hopefully you're paying attention to the arteries, and you underline those two arteries that I asked you to. We're going to move this along for our old schoolers, but I got to keep on going because I got a lot more to say. All right, pulse behind the knee was the T, popliteal, and pulse at the thumb side was the radial. So y'all say that with confidence and authority today because I'm here to say yes, that's correct. But on the Hesi test, you're going to be like, oh, you said it was the only one. Ain't no on a pulse. You gonna say it's on?
No.
Okay, all right. Just saying, man.
I know that works. I know those.
You know that. Okay, good. Okay, moving right along to the veins. We don't have a whole lot on veins. We don't have any questions on veins.
Okay, I'm still writing the last one.
You gotta slow me down.
I'm still writing
No, the
too.
last one. You can write the first one.
All right, let me erase them both of them because I gotta keep on moving.
What was the second part of the question? The answer?
With the
radial
first
pulse.
No,
The second part was the radial pulse. Thank you.
All right, we're going on to 17. We got to talk about these things before we get there. So we got our veins. Remember, veins are carrying blood back towards the heart. You're going to go about from the same direction. Remember, they're going backwards, so they're going out from the same direction that the other veins, the arteries, are going. So you have some that are flushing out from your head. Usually it's close column or carotid, we call called the jugular. And some that are coming back from your arms, you're going to have that going from the axillary again. Now inside of that portion, which will be for your elbow, it's a place where people like to draw blood. That'll be the median cubital, that'll be the fold inside of the elbow. And usually inside of your wrist, they also call that a different name. I think that was called venous arches. I don't remember what they call them on the actual wrist, though. They shouldn't be drawing blood from your wrist. On your descending vein is going to be the inferior vena cava as opposed to the descending aorta. It's also going to have a one for the left and right leg. And remember, this is going backwards. So it's going backwards from the knee. Still going to be the popliteal vein as opposed to the popliteal artery. And it's still going to be the dorsalis arch on your foot and posterior tibial on your foot going back. Now, when we looked at that for the capillary, now remember the capillary is where we do that exchange portion. That'll be where we're taking it in from the arteries, so we're taking in the high oxygen blood, and then going back towards the vein, we're taking the low oxygen blood. So the capillaries are going to be that exchange portion, and then the smaller vessels are going to be called the arterioles and the venules. So now we look at the actual heart. Now the heart is going to start on the right side from what we saw. Oh, you guys got my systemic circulation, which I told you to get. Now remember, the pulmonary circulation is only the exchange, and if you're looking at that picture, that same picture I got on the slide, you guys have on page 17, that is only the exchange between the heart and the lungs. So it's not the exchange with the outside environment and the inside environment. That was exclusively called external respiration. So pulmonary circulation is just the heart and the lungs. Systemic circulation was that entire process that I just spent the last 2 minutes describing to you. So now we're on our thing for the heart itself. So we're going to have the heart have blood coming in and moving out. So we got our blood coming in on the right side. Now remember, chambers that receive blood, or smaller chambers that receive blood, are going to be called the atrium. So the blood's going to be coming in with the inferior and superior vena cava. Now the vena cava is going to empty out into the right atrium, and then the right atrium is going to hold the blood for just a second before it releases. So it fills it up on a probably a 100th of a second, 10/100th of a second, depending on how fast the heart is beating. Then it'll release that blood with what we call the tricuspid valve. The tricuspid valve is going to open up and is going to make an emptying sound. Usually they call this the dove love sound, as one of the valves open and the other valve is going to close. So as the ventricles fill up, the atriums are going to empty, and then the door is going to close, and then the ventricles are going to pump the blood out towards either the lungs or towards the heart, the rest of the body, which we'll call the aorta. So this is going to be on the right side, the right atrium, tricuspid, to the right ventricle, and it's going to go out towards the pulmonary artery. So the pulmonary artery is what carries blood away from the heart. I have had that as one of the questions. I was going to tell you guys to underline and highlight it on that next page for page 18. But one of the questions that gets people more than that one is what gives the blood supply to the heart, or where does the heart get its own blood supply from? And that's this little thing right here on my picture that's not even labeled, called the coronary artery, which is going to be on the next page. So when we get to that page, I'll remind you guys to underline or highlight it. So back to our heart, we go out towards the lungs. We just got done describing that portion. We're going to bring the blood back with what we call the pulmonary veins. So the pulmonary artery is going to have the low oxygen blood. Pulmonary veins are going to have high oxygen blood. And it's going to go back towards the left atrium. Now the left atrium is going to use what we call the bicuspid or mitral valve to empty out into the left ventricle. Now on the chart, on the picture, you should note that ventricles are much, much larger than the atriums are. So atriums are much, much smaller in size than the ventricles are. So the atriums are going to be the receiving chambers, and the ventricles are going to be the larger vessels, and they're going to be the pumping chambers, which are going to be on the bottom portion of the heart. So the left ventricle, which is the largest of the large chambers, refills up, is going to pump out the blood toward the aorta. Now the aorta the largest artery in the body, if I were to ask you that question, which I don't think is on here, is going to go out towards all of those other arteries that we just spent the last 5-10 minutes labeling. So before we move on, go to page 18, and we'll look at a couple of the terms I wanted you guys to remember. So we wanted to remember our ventricles. Over to page 18, you guys can see, before I answer the question, give me a minute here. You guys should see the aorta, so underlining coronary artery, coronary veins, and aorta, and then sinoatrial node. One more time, on page 18, we got coronary artery, coronary veins, aorta, and then sinoatrial. Okay. So with that said, that's why I won't lose my train of thought, so you guys slow roll me a little bit. What was the largest chamber of the heart? That was the left, very specific, please be very specific, left ventricle. All right. And then what is the name of the blood vessel that delivers oxygenated blood to the heart muscle? Coronary artery. All right. And then the chamber of the heart that has the thickest walls were just the ones that are on the bottom. Those are on the ventricles. You should see the people behind you. Hey buddy, I was just talking about you. Ah! They look so confused back there. It's like I'm speaking another language.
You are.
You know what?
You are.
I am telling you the things that are medical terminology. That's all I'm doing, is telling you the stuff on the Hesi test for medical terminology. Now, if you find this confusing, take the medical terminology class.
I do take medical terminology.
But you got to take it with me, so I can break it down so you understand all of the things that are the things. You'll have a very high level of things once I tell you about all of the stuff. You're like,
Lots
yeah,
of things.
he said.
Lots of things in the stuff, guys. Lots of things.
You taking the test in September. If you didn't hear because you were late, it's getting harder in January. So you need to make sure that you get past this in September. For our folks who did come in, they are changing the score from 75 to 80 in January. So if you're taking this for this September, still 75%. Taking this in the time to get in for May, you're going to change it up to 80%. A couple other changes that I don't want to be the bearer of bad news, because all of it's bad news, but I don't want to bust you guys up with bad news all day, so I'll tell you that at the end. All right, I'm going to skip over and gloss over our pacemaker, so we're going to skip over that electrical flow, because I'm going to spend my last 15 minutes talking about some blood. So we've got our thing for our coronary arteries and coronary veins. All right, so you guys got your sinoatrial node. The question was, what's the pacemaker of the heart? I'm putting that up there, and I'm not going to have time to talk about it, so that means just remember what it is. It was the sinoatrial node, and please do not write down in your old school notes SA node, because there are no abbreviations on the Hesi test.
Is it multiple choice? Yeah.
All of the science is multiple choice. But like I'm trying to prepare you, if they're talking about DNA, they're going to write out deoxyribonucleic acid.
Oh, okay.
They are not going to write out DNA. If they're talking about carbon dioxide, they're not going to write CO2. So you're going to write out all of the 15 letters. So you're looking at it like she's looking at me like, what'd you say?
No, I'm saying like that.
They're going to have all of the words. So don't shortcut it. That's why I'm giving the old schoolers time to old school me today, because they're going to have the word that 15 letters in it. I had up to 13. I know, right? That's sure to be my 2 letters. Okay, I got to move on. Hold on a second. You got that one down, Sherry?
Yeah.
First pat on the back I done gave you.
I know a lot of them.
All right, we're moving on. There's 2 questions on there, Sharon. Okay, so we're talking about blood and immunity. So blood is going to be with what we call erythrocytes. Go to page 19. Then we're up to page 20. So we got our blood. Underline or highlight where it says erythrocytes. Underline or highlight where it says hemoglobin. I'll tell you guys about the white blood cells, but you'll have to write that stuff down as we go to it. Okay, so a couple statistical things we need to know about the blood. In the average person, we're going to say people are going to have between 4 and 6 liters of blood. And that 4 to 6 liters of blood is going to be different for the male. I think they still do this. They may not. We're going to see if they do though. And in the female, in the male, it's between 5 and 6. In a female, it's between 4 and 5 liters of blood. Okay, now that blood actually has a charge to it. It's the same thing as drinking some water. So if we had our little pH scale here on the 0 side, we're going to call that an acid. And then on our alkali side, we're going to call that as a base. And blood is usually right there in the middle, which is going to be 7.35. So the pH of blood actually doesn't have a charge to it. It's the same thing as water. So if we did that for our blood, and they ask you what the pH of blood is, it doesn't have a charge. So that's kind of a trick question. Blood itself, the red blood cells or erythrocytes, are all going to come from and they like to ask a lot of questions about blood because blood is one of the trickiest things to talk about. Blood comes from the red bone marrow and the stem cells. Then blood is going to move from there towards the arteries and veins. Usually it'll be stored in the liver and in the spleen, and then when it gets worn out and broken down, it'll go towards the liver to be converted back into bilirubin. So the bilirubin is actually going to help bond with the hemoglobin, which is going to hold that oxygen and carbon dioxide, so there's really no need for the red blood cell to have a nucleus attached to it. So when we say that, I'm going to ask you my statistical questions. And blood, inside of the blood, is actually for the purpose of bonding with oxygen and carbon dioxide. So what's the normal pH of blood? I'm not going to write that one again because I wrote it down already. 7.35. So write down the question, but I already got the answer up there. And what would the volume of blood be for the average male? Notice how I did the specific? Now, do you remember that if they asked you that? You don't remember.
I do remember.
Which one was it?
The pH of blood. I can't remember if it was in the
You don't remember? Okay, but it was the thing in the thing. Okay, that's scientific. I'm trying to write it up there. So the male and the female are different. So if they ask you for the person, it's 4 to 6, but it could ask you for a male or it could ask you for a female. And I don't like the way that they do that question because with the one that's for the pH, usually with the science questions, it's very obvious what the wrong answers are. But they have all of the numbers up there. So they have 7.15, 7.25, 7.55. It'll have all of the numbers up there, and you have to pick the one that's closest to it. So 7.35 is the one that you should pick. You're not going to remember it.
I don't remember.
For
You wrote
which,
it down.
for the first,
All
or
right.
the second?
Hey, buddy, how's it going? You stalking me a little bit? I do enjoy the company. Come on in and grab a seat. No, wait for me in the lobby. I'm be done with them in 5 minutes.
Okay.
Okay, I won't forget you. Okay, so we're moving on because my slow rollers are still slow rolling. Hold on a second. Ma'am, you done in the back?
What do
You
we
waiting
say
on me?
answer for the second?
Oh.
Yeah,
Right there.
Oh, that's the same thing? Oh, okay.
Yeah, I already wrote them down. That's why I didn't get back up and write them
I just
down.
wanted to make sure that was the same answer.
Okay, so we got our hemoglobin, like I said, that bonds with the oxygen. It's actually iron, which is the main component of it, and that's usually what gives it its charge to hold on to the oxygen and carbon dioxide. And then the bilirubin, like I said, is going to hold on to the hemoglobin. So we need to have both of those in place in order for the blood to do its thing. Now moving on from that to the white blood cells, we got 2 different kinds. I know you guys are masters of the polymorphonuclear nucleocytes. But I'm going to tell you about the granulocytic nucleocytes to go along with that. I know it's like speaking another language. So let's take a look at the picture. Then the little ones that you see the dots in, the basophils, the neutrophils, and eosinophils, those are usually going to be what contain things that are going to be for our first type of invader who gets on our nerves, and that's going to be called a antigen. Antigen are things that are going to trigger the inflammatory response. So these are things that we don't really like, but they aren't going to kill us. So these are things that are going to be like mold or pollen or things like a fungus. Sometimes the fungus might kill us if it gets the wrong kind. And then the pathogen, though, that is a thing that will kill you. So the pathogen is going to be a thing that those polymorphonuclear white blood cells, like the monocyte and the lymphocyte, are going to have to take care of. So those would be things like the virus, and these will be things like the bacteria, and in most cases things like fungus. So it'll be things that we don't want to be on the body or in the body. So these will be specially programmed, and usually when we say that with the antigen, they are specially programmed already. So you may have an allergy, like we have an allergy to mold or pollen or dust. I was going to write that up there, but it just came to mind. So you may have an allergy that may make you cough or sneeze, especially if you get it in your nose or your throat. So that's what these are for. Then when we talk about those, these are more the defenders, which are going to cause that inflammatory response. But the inflammatory response is going to be for the purpose of getting rid of invaders. So that is what the pathogens are. They are invaders. And usually this is going to be done with this process called this phagocytosis. And that means that we're going to catch up to those invaders. We're going to absorb the invaders, break them down, and get rid of them or get them out of the body. So this is usually where the lymphocytes are going to be specially programmed, especially if you're up to date on your vaccines and shots. Then it's going to know what to do if it sees some chickenpox virus or some E. coli bacteria. If everybody weighed at Wendy's, you might have some E. coli bacteria. That stuff can't even eat the lettuce and everything. So they're going to catch up to those invaders. Now, a lot of people are usually under the impression that the antibiotic is for the purpose of killing those things like the bacteria and the virus. But usually it's so it can stop the growth, and the lymphocytes and the monocytes can catch up to them and do the phagocytosis portion. So that usually is where we get rid of our invaders. So I'll ask you guys that about the phagocytosis coming up in just a bit. So we'll take a look at our last, those are our 5 white blood cells. Go to page 20. Take a look at our last portion here after I answer these questions. And that's going to be our last little component with the blood cell, and that guy was called the thrombocyte. Okay, so part of the white blood cell that helps with the phagocytosis, that is called the lysosome. And then the major component of plasma, I'll ask you guys what you think, but y'all sometimes brutally disappoint me and hurt my feelings. I'm going to go for it anyway. Oh, somebody said it. It was what?
Water.
All right. Woo-wee. About to get disappointed. Water. All right, so all of this stuff is floating around in the water. Actually, blood is about 55% water and plasma and 45% blood. So it's not really a lot of blood inside of blood. Now, did you always write that small, Ariana, or did you just start writing that small? Okay. Because I remember you used to write bigger. I need a microscope to read.
This is actually bigger.
Oh, my goodness. Kind of scary. Let me borrow your glasses here. I gotta read this. I don't think you wrote the right thing. I'm distracted. You write faster so I can move on. I got one lady in the back, old school. All right, we're going to move on from there. So we remember our antigen and our pathogen thing. Now we're going to move on to our last component of the white blood cell, which is called the thrombocytes. And that's this little guy way over here. I'm going to go back to the picture of him in just a second. So that is actually for the purpose of creating a blood clot. So a thrombocyte, which I'm going to ask you guys that. Go to page 20. On the top of page 20, underline where it says platelets. on the bottom portion of page 20, underline where it says plasma. And then we need type O, type A, and type B. Okay, here we go. So the platelets are actually fragments of blood, and they begin to collect at the site of an injury. Typically, what triggers this collection is going to be the release of this fibrin, which is going to come from thrombin. So the thrombin is actually going to convert itself if there's an injury. So if I were to cut you, you have a cut, the blood's coming out. What's going to happen is, it's going to be in the top portion. The thrombin is going to say, oh, we got cut. Then it's going to convert itself into that fibrin. So the fibrin is actually going to start creating a net. And that's that white particles that you, those yellow strands that you see there. And they're going to start to gather in the little platelets. So this is going to happen until that injury is going to occur, and then we'll have this process stop once the wound is healed. I might have a question about that later. There's a big fancy Hesi word that's going to come up about that later. So once that is going to happen, and we don't need the clot to happen anymore, then we'll have heparin be released, and then that thrombin is going to, that fibrin is going to go back to thrombin, and then we won't have to worry about the clotting process happening. So if the person is stationary or sitting in one spot, we may have to get them to move around so that that thrombin doesn't just spontaneously occur, and they get excess blood clots, which could cause problems. So now we look at our actual blood that's in the blood, and we're going to have a little chart up here. So our blood types are going to be separated by who they are. Usually, most people don't know what their blood type is, so I'm going to take a little guess and say, let's see here. All right, what's your blood type? Type A?
I have no idea.
I'm
No
O.
clue. What's your blood type? Oh, what's your blood type?
I told you I don't know.
You said you don't know. I've asked you this before.
Yeah, I
Oh,
told you I don't know.
hold on a second. She knows. What's your blood type?
I don't know.
Oh my! You're supposed to have learned this answer. Okay, never mind.
I asked my mom, she doesn't even know.
You know what? I'm gonna have to go do the thing with
I think I'm O positive.
All right. Somebody said they were.
I'm O
I'm O
positive.
positive.
You're O positive. Okay. Thank you for telling. So you're O positive. All right. We're gonna write O, and we're gonna write A, and we're gonna write B. All right. So one thing we need to learn is that A don't like B. These guys don't get along. So usually A is going to have an anti-B antigen, and B is going to do the same. He's going to have an anti-A antigen. Now remember, this isn't going to kill you, but it will definitely cause the inflammatory response to kick in. So if we were to give a person a blood transfusion who has type A some type B blood, you would actually get sick because A has a type B antigen. Now the person, you guys who said you're a type O, thank you for being type O, that means that you have no A or B antigen. So that means that the type O person could actually give, but the positive Rh factor, we'll talk about that in a second, can give to A or it can give to B. So usually that is going to be O gets along with everybody. Now I put AB up there, but AB would be down here. It's very rare. Most of society is going to have O. It's probably about 45%. You don't need to know the percent. That's not on the Hesi test. And this would be about 20 to 25. This would be about 30 to 35. So that really eliminates just about everybody except for AB. This would be about 4% if we actually had to put a number to it. Now again, stuff that you guys don't need to know, but very interesting facts to find out. So once we put that, AB actually has an A antigen and a B antigen, so they can receive blood from O, A, or B. That's why I put that up there. But most of the time they don't ask you that, so you don't really need to know. So the Rh factor, which is the only other thing that we haven't covered here, is going to be for positive and negative. Now usually positive likes to give to, let me go like that, other positives, and negatives like to give to other negatives. So that means that positive and positive, they get along, negative and negative get along. The only case where we have a problem is where we try to give a positive to a negative. So this one, positive to a negative, is a no-go. So that one would be something that's going to cause an Rh factor, or one of those rare cases where a Rh factor, which is a positive and negative, could make a person sick. So we have to match it up So if you actually did the math in your head, you ladies seem like you're halfway ready to take the Hesi test, at least the science portion, then would the person with O negative be able to give to a person with O positive? That would be a yes. But the person wouldn't go backwards. So the person with positive would not be able to give to a person with negative. Did you just figure that out? You gonna write it down now? Don't slow roll me. Last set of questions. We're gonna take a little break, and I'll tell you guys the last bit of bad news. All right, I know I have more. I'm just beating you guys down with bad news. The score going up, the money going up, all this stuff is messed up. There's one more thing that's messed up. I'll tell you about it in just a second.
Ain't no break.
Function of the thrombocyte was. You're supposed to be like just the thing with the stuff in the thing. She already said it was the stuff.
The clotting process.
Thank you, man. Thank you. All right, clotting process. All right, we're gonna say begin clotting process. Okay. Next question. Type A, type B person has what antigen in it? Is it O? It's A.
Anti-A.
All right, so he don't like A. So it would be an anti-A antigen. All right. And what type does not have an A or B antigen?
O.
O. So O loves everybody. All right, and then the last portion was with wound repair, and that's actually the answer. Cellular contact inhibition is important in the process of healing in what we call wound repair. That term just means for wound repair. It just means that once the repair process starts, inhibition means that it stops. Once the thing is going to hit something else. So once the cells, or once the repair starts to hit something else, we're repairing the blood vessels. So once we start to hit the bone, or once we start to hit a vein, then it's going to stop. So cellular contact inhibition means that the repair doesn't go on infinitely. It stops once it hits something else. Okay, I'll give you guys a minute to old school that. So the other bad news that I had to break for you was that next year, for 2023, you will have a waiting period, which is going to be a 1-year waiting period.
Oh, my.
So, yeah, man, it's really bad news.
That's
So let's suppose you take the test and you can't wait to take the test. You come right in here, you take the test. This isn't until next year, by the way. So you come right in here, you take the test in February. You say, oh man, Mr. Moore didn't tell me that was going to be on there. Yes, I did. But you're going back, you didn't get the phone thing, you didn't look at the stuff on the phone. You ain't going to do none of this, are you?
Yeah.
Okay, you're going to study all of this stuff. Because I'm telling you, it's a 1-year period now.
Okay.
So it's going to be, so you go back and you say, okay, I'm taking it again in May. So the deadline's in May, I'm taking it again in May. And then in May, you'll be like, oh man, what happened was, they're going to make you wait an entire year until May of 2024.
Since we take
And
it
you'll
again.
take it again.
Good.
So that, yeah man, that's a kick in the face right there.
Why are they doing that?
Because 2 reasons. They find that too many retakers are coming back and waiting 45 minutes, and then allegedly they
45
believe
minutes?
45 days or 60 days. I think they're going to change it to 60 days. They didn't tell me that officially, but most likely that's going to be what happens. You'll have to wait 2 months before you can retake the test. But they believe that more people will have the opportunity to retake the test, to take the test if we don't have so many retakers. I don't necessarily agree with that because this is a hard test and it gets harder every time you take it. But they say you should take it only twice each year. So the other things that may change, I'll let you guys know if I hear about more changes. We're going to pause for the calls because that was the end of my little show. Thank you for sitting patiently through my little show. If you're sticking around for reading, Mr. Winston will be in here at 10 to the